Hello, everybody. My name is Taylor. I'm going to talk to you guys about health insurance. I really hope I can get through as much information as I possibly can. I have a lot of information and it was very hard to kind of condense it down. So hopefully I cover everything you guys might have questions about with health insurance here. Okay, perfect. So we'll go over some keywords, types of insurance, commercial, private, Medicare, Medicaid. I mainly meet with organ transplant patients, so we'll go over how it works with like kidney transplant and so forth, and then also like changing insurance, what to do when you're switching employers, loss of employment or retirement. I'll have other resources too available at the end. The disclosures here are full disclosure though, I do talk very fast. When I talk fast, I have the slight Iowegian accent, so I apologize. Again, my name is Taylor Casey. I am a certified transplant financial coordinator. Do this every day of my job. Working with transplant patients for the last 5 years. Okay, so keywords. You guys might have seen these words before, but I have some definitions for you. There's COBRA, co-insurance, co-payment, deductible, HMO. HMO is just a type of insurance program or health maintenance organization, tells you where you can and can't go for services. Then you have out-of-pocket maximum, premiums, and then PPO is preferred provider organizations. So just again, tells you where you can and can't go for with your insurance. Types of insurance again, commercial, private, Medicaid, Medicare. They all kind of overlap. They have some similar characteristics to each other, but sometimes they're just vastly different than other types of insurances. So with commercial and private coverage, you have your employer group health plans. Their insurance is offered by your employer. You pay the premium, your employer might contribute to the premium cost. So for some people, their employer covers the entire premium. Some people, they have to pay a good chunk of it or all of it. It really just depends on the employer. You have PPO or HMO plans offered. Again, PPO plans are more broad spectrum. Those are plans that are usually accepted at a lot of different places. You can usually take your coverage to other states as well. So kind of free range is what I call those plans. And they have HMO plans. HMO plans are restrictive. They usually want to keep you in that state that you live in, or they want you to go to specific organizations. So like, I know here in Iowa, we have like Unity Point is one of the organizations. We have Mercy Ones. There are specific insurances that might say you can only go to like Unity Point providers or go to Mercy One providers. Some of them say you can go wherever is contracted with the insurance. There's also a few other ones that are newer. There's exclusive provider organizations, EPOs. Those work more like an HMO plan. They're a bit more restrictive too. I've seen plans out of Illinois that are very much basically, they only cover you for Chicago providers. You really can't go outside of Chicago if you live in Chicago. There's also point of service plans. It's an acronym I'm not very fond of, but those you see in your cards, those are similar to PPO plans, but they act kind of like HMO plans, but they're still a bit more friendly where you can still go to a lot of other providers. Deductible out of pocket. Deductible is the amount of money that you spend. So let's say you have a plan that has $1,000 deductible. You have to spend $1,000 out of your own pocket first before then the insurance will pay for any services. So pay $1,000 first, then you'll have your co-insurance or co-pays for visits. Some insurances, you might have a deductible, but your co-pay for certain services like office visits, you might have to pay those co-pays first before meeting your deductible. They all kind of just work really differently. Then you have out of pocket. So your out of pocket is the most you'll spend in the entire plan year, excluding your premiums. So let's say if a plan has $1,000 deductible, but a $2,000 out of pocket maximum. How most plans are structured is that you pay your $1,000 deductible. Then you have a co-insurance or co-pay. So let's say you have a 10% co-insurance, then you pay 10% of services after you meet your deductible. And then once you've spent $2,000 out of your pocket, so that includes your deductible and all your co-insurances, co-pays to meet that $2,000, then you're done paying for the rest of the year. So let's say you have a big surgery at the start of the year, that means you're out of pocket at $2,000, you are done paying for services the rest of the year. So some of my patients I see usually meet their deductible really, really fast and they're out of pocket based off all their services. Prescription coverage. So a lot of commercial plans will also include prescription coverage. Some of them will either be built in with the medical plan or be a standalone plan. So a lot of plans, like I have a Blue Cross Blue Shield plan, and built into the plan, they have a CVS Caremark pharmacy plan. Sometimes you'll get a card that just has both your like Blue Cross and your pharmacy coverage on it. Sometimes your employer might give you a separate card for prescription coverage. A lot of times with prescription coverage, the costs are also embedded with the medical plan. So if you meet your deductible and your out of pocket for the medical, you're also meeting your out of pocket and your deductible and out of pocket for the pharmacy plan. Sometimes they don't work together, so you'd have to pay double basically. So your medical plan, you pay that deductible and out of pocket, and the pharmacy has its own separate deductible and out of pocket. Marketplace plans. These are plans offered through healthcare.gov or a licensed health insurance agent. If somebody says, oh, we just get a plan through Marketplace, don't Google Marketplace plans, just go straight to healthcare.gov. If you Google Marketplace plans, you might get a lot of ads, a lot of scammy sites. So go to healthcare.gov, please go to healthcare.gov or ask or see if there's a licensed insurance rep in your area that can help you find a plan. Premiums paid by a subscriber, which would be yourself, you pay for your own premiums. Now with the Marketplace, healthcare.gov, there are income-driven subsidies. So if you make under a certain amount of money, you could get a subsidy towards that premium. So instead of paying $500 a month for a premium, you end up spending maybe $200 a month because your income is within the threshold to pay a lower amount. Some patients I have zero premium. They have a Marketplace plan. They make a little bit too much money for Medicaid, but because of their income being so low, they end up qualifying for a zero premium Marketplace plan that usually is very well, but has very good coverage with it. So like very low copays, low out of pockets with those. Marketplace plans, at least in Iowa, most of the plans available here are HMO and EPO plans. I have seen other states that are really nice to people using the Marketplace, and they offer PPO plans as well. So some states will offer plans that will go outside of the state, and other states will want you to stay within that state that you're buying the plan out of. They also have a deductible out of pocket, co-insurances and co-pays. They also, the Marketplace, they almost always include prescription coverage with them. And I've always seen them embedded with the cost too. So there's no separate deductible, no separate out of pocket. They all kind of combine with the medical coverage. And you cannot purchase these plans if you're already on Medicare or Medicaid. So if you have Medicare or Medicaid, they're not legally allowed to sell you these plans. Although I have seen people get them that way, and that can cause problems later tax-wise if you purchase these plans while you knowingly have Medicare or Medicaid. Medicaid is a state-run health insurance program that is for people who are low income or on disability. Some states have the expanded Medicaid. So like Iowa, we have expanded Medicaid. So Medicaid is available to not just people with disabilities, but also people who have low income. You have to have your income be under 133% of the federal poverty limit, which still isn't a lot of money. But with Medicaid, it's pretty comprehensive. A lot of states will have either their standard Medicaid or they'll have you go into what's called a managed care organization. In Iowa, I rarely ever see people on standard Medicaid. They're usually on one of the Medicare organizations, such as we have like Iowa Total Care, WellPoint, and Molina. Those are three we have. Other states have other ones too. So that's how they work here. And so they're low to no cost. So depending on how your state has done their expanded Medicaid program, some states you have some copays, like some states have a, like here in Iowa, we have $0 to $3 copay for medications. If you go to the emergency room, there could be a copay of like, I think it's usually pretty low too, like $3 to $5 for a copay there. Other plans have no cost. Again, it really depends on which program you end up being assigned. It is also a payer of last resort. So you can have Medicaid in combination with employer group coverage or with Medicare. So you'll have those plans pay first, either the employer group coverage or Medicare, whichever one is there. And then Medicaid is the one that pays last. And usually when you have an employer coverage or Medicare and Medicaid, you end up paying nothing out of pocket because your employer plan or Medicare will pay first. They pay a good chunk of everything, and then Medicaid picks up the rest for you. Medicare, this one's a bit of a beast here. So with Medicare, you have a Part A, it's hospital insurance. It has deductible co-insurance, no out-of-pocket maximum though. So you just keep paying the whole time you're on that. Medicare Part B, that's medical insurance. So the difference is hospital insurance. So Part A is when you're inpatient, like surgeries and such. Part B is medical insurance for when you go to doctor's visits, like, so an office visit, you pay, your co-pays and such for that. So, there is a premium to Part B, but not to Part A, for most patients. With Part B, it's a pretty low deductible, or sorry, low premium. There's a deductible, co-insurance, and no out-of-pocket maximum. And then to have original Medicare, you also want to have a Part D plan. That's just prescription coverage. Same thing, has a premium deductible, co-pays, co-insurance, and that does have an out-of-pocket maximum. And then we usually encourage patients to have a Medigap plan with the Medicare. So Medigap is supplemental insurance. It covers whatever's left after Medicare pays. So Medicare pays 80%. And then the supplemental Medigap plan will cover the remaining 20% for patients. You can use anywhere that accepts Medicare. Medicare Advantage plans, those combine parts A and B into one plan. You continue to pay your Part B premium. You may have a separate premium for Medicare Advantage plan, but most of them are $0 plans you add on there. They sometimes have a deductible. They have a copay, co-insurance, out-of-pocket maximum for those. There are two different ones. You can have a plan that includes pharmacy coverage, or you can have one that does not include pharmacy coverage. The plans that include pharmacy coverage work really well. The ones that don't include it is usually meant for patients who also have like VA benefits. They also offer benefits that are not found with original Medicare. So they have vision, dental. I've seen patients get plans that have energy assistance and food assistance as well with them. It's usually the special needs plans. The issue with Medicare Advantage plans is they do restrict your care. So if you have a Medicare Advantage plan, it's basically an HMO plan. You can only stay either within the state you purchase the plan through, or stay within the hospital system that provides the Medicare Advantage plan. With original Medicare, you can go anywhere that accepts Medicare. You're not restricted to stay in your county or your state. You can go wherever you please. For organ transplant patients, it's a pretty broad rundown here with that. So most employer plans, they do cover organ transplant. It's not required by the ACA to cover organ transplant though. So I have seen plans that do not cover organ transplants at all. I don't like when I find those plans, but I have found them in the last 5 years. But most of them do cover organ transplant. Marketplace plans typically cover organ transplant. I've yet to find one that does not cover organ transplant. Commercial plans can restrict where you seek care. So there's a lot of networks that are involved. I can get into it a little further, but I don't have the time. Just know that some plans can dictate where you can and can't go for transplant care. You'd also want to verify if the coverage requires you to have Medicare. That's kidney patients, but so some plans might require you to have Medicare if you're eligible for Medicare. That's go more in depth on that later. You also would want to verify if the plan covers like living donors. I know that a lot of patients have to have living kidney donors, and for the most part, commercial plans cover living donors. But I've heard of people having plans that don't cover living donor, or only cover living donors if they are also on your health plan, so like a spouse or child. Medicaid plans, they all cover organ transplant. So if you have just Medicaid, it will cover transplant. Low to no cost. I have patients who have Medicaid. They don't pay anything for transplant services, so they're pretty relieved when I tell them that. They may restrict your care to your home state. I have had patients though who don't live in Iowa but want to come to Iowa because where they live, they don't have that program that they're looking forward to for an organ transplant. Some states are nice about that, will allow you to go out of area for that. They are strict on medical criteria, so to get authorizations and everything like that, they want you to go through a lot of testing before they give me approvals. They do cover living donors. And then for original Medicare, they do cover organ transplant if both Part A and B are active. You want to have both parts active for transplant for the most part. There's other exceptions to that rule though. You can go anywhere that accepts Medicare. So most transplant facilities are Medicare approved. So as long as it's Medicare approved facility, you can go there for organ transplant. Our facility, I've met other centers that don't require this, but our facility, we require you to have supplemental insurance to Medicare. So you can't have just Medicare A and B, you have to have Medicare A and B and a supplement, or Medicare A and B and commercial coverage or Medicaid. or even get a Medicare Advantage plan. And then we also require Part D prescription coverage. And then the Medicare Advantage plans, oh, and they do cover living donors. Medicare Advantage plans, they cover organ transplant for the most part. They do restrict care. I've had patients that live just in the Quad Cities on the other side of the state, and they want to come to Iowa for their transplant, but they're told by their insurance they had to go to Illinois for all that. Can be strict on the medical criteria. Original Medicare doesn't require authorizations, but Medicare Advantage plans do. So if you have Medicare and you switch to Medicare Advantage plan, we had to get all these authorizations in place for that. They do cover living donor as well. So Medicare for kidney transplant, when to enroll. If you start dialysis, you'll start the 4th month of hemodialysis or the 1st month of peritoneal dialysis or home dialysis. Time of transplant, you can also enroll then. So if you didn't enroll during dialysis or didn't have dialysis, you went straight to transplant, you can enroll at that time. You have a year to enroll into Part A and B. Coordination of benefits, this is really tricky here. So if you were to enroll into Medicare, either at time of dialysis or at time of transplant, Medicare is secondary to your commercial insurance for the first 30 months that you're on Medicare. Once that 30 months is up, then Medicare becomes primary for you. There are some exceptions to that rule, but don't see this very often. And then the coordination of benefits starts on that 1st or 4th month, depending on your modality of dialysis. If you transplanted prior to dialysis, there is no waiting period for the Medicare. You can start at that 1st month, you just go back onto dialysis. If returning to dialysis 3 years after transplant, your coordination of benefits period starts again, but there is no waiting period. So you can start again. Medicare would be secondary for the first 30 months and then become primary. Things to consider. A lot of employer-sponsored plans do require you to pick up Medicare when your coordination of benefits period ends. So you want to talk to your employer and ask them, is my plan punitive? That's the word you want to think about. Is my plan punitive? That means they would require you to have Medicare when Medicare becomes primary. If you don't have Medicare when it becomes primary, your insurance plan could not pay claims. So if they think you should have Medicare primary, they're going to want that plan to pay first. You'll also want to have Medicare Part B if you want immunosuppressant coverage. You need to have Medicare Part A at time of transplant and then pick up Part B later down the line to get the immunosuppressant coverage. That one's also a little tricky. If you want Medicare coverage for living donors, so Medicare does pay for living donors. If you have a living donor and they have complications later on in life from donating a kidney to you, your Medicare coverage covers them. They wouldn't have to go through their insurance plan. It'd be covered 100% by Medicare. So that's one thing to consider too. And then Medicare coverage lasts for 3 years post-transplant, unless you're eligible otherwise due to age or disability. So I have some patients who will get a transplant age into having Medicare because they turn 65 within that 3-year time frame. So they just keep their Medicare. Other patients are disabled for other reasons and they keep their Medicare past that 3-year mark for that reason too. Medicare Part B ID. So I have some patients who've transplanted. This is a new thing. So with Medicare Part B ID, it is expanded coverage for immunosuppressants. So let's say you transplanted, you no longer have Medicare, but you don't have any coverage and you need your immunosuppressants because they're expensive. You need them to keep the organ. So there is this Medicare Part B ID, but it comes with a lot of exclusions. You must have Medicare at the time of transplant and carry it for the full 36 months of eligibility. So the full 3 years post-transplant. You cannot qualify for any other coverage. That is very rare. Almost everybody qualifies for some sort of insurance coverage, either through your employer, through the marketplace, through Medicaid. There's almost always a coverage option out there for you. So last time I heard about this was that they predict only, I think 200 people nationwide would actually qualify for this program. They tried. I know that they probably came to Congress with this really big, robust plan to help transplant patients with really good ideas. And then everything just got taken away from it till it got down to what it is now. But I know they probably tried very hard. You are subject to Medicare Part B out-of-pocket expenses. So Medicare Part B only pays 80%. You're still on the hook for 20% coinsurance. It is a reduced monthly premium. I believe it was $94, a little under $100 a month to still have this plan. And it, again, only covers immunosuppressants for you. And there's also some income-based assistance though. So, you might qualify for, plans that can help or assistance through Social Security or through your state Medicaid to help pay for this program as well. And if you're wanting to look into applying for it, you have to apply through your local Social Security office or call that 877 number. They do not allow you to sign up for online for some reason. I tried looking that up for today. Can't sign up online. Changing insurance. So new job, you typically have 60 days to enroll in the new employer coverage. Some employers have a 90-day waiting period. I know that's pretty common anymore. So if you're there for 90 days, that's when you can finally enroll into your insurance plan through them. If your new employer does not offer insurance or is not affordable to you, you can purchase a plan through healthcare.gov. You have 60 days to enroll prior to loss of coverage or within 60 days of losing coverage. If you do not enroll at that 60 days after losing coverage, you cannot enroll into health insurance through healthcare.gov. You have to have a qualifying event. So if that ever happens, make sure you get on that really quickly. And then you also have the option for COBRA coverage. If you're left an employer and going to a new employer, but not able to either get that plan or Marketplace isn't an option, COBRA is also an option. You get that paperwork when you leave that employer, the previous one. COBRA, that is for you lose your job and you're kind of waiting for the next job. You can opt into COBRA. It's 18 months of coverage. For some patients, you have a disability that does get extended. You can also go to healthcare.gov. And again, 60 days to enroll from that loss of coverage. But let's say you missed that 60 days to enroll, then there's open enrollment from November 1st to December 15th. Medicaid, if you are without income, you can also try enrolling into Medicaid if you live in a state with expanded Medicaid. So if you lost a job, have no income for the meantime, you can try enrolling into Medicaid for coverage. Retiring, you have the option for COBRA. My dad recently retired. The city that he worked in did not offer any retiree insurance coverage, but they did offer him COBRA. Well, obviously he's not going to go for COBRA, and he's not 65 yet. So that's not usually the best option, but it is an option. Some employers have sponsored retiree insurance. I know like the University of Iowa does. A lot of other employers do. It depends on the employer, what they want to do for their retirees. You can go to healthcare.gov to get coverage to cover you for that gap between retiring and turning 65. And then you also, let's say if you are 65, you retired and you already have Medicare Part A because you're 65, that's your time to enroll into Part B. You have a special enrollment period of 8 months from when you retire if you already have Medicare Part A to enroll into Part B. Make sure you enroll into those plans because if you don't enroll into them within that special enrollment period, you could face a penalty.
Good question for you. My daughter turns 26 next September,
Mhm.
and that's when I guess they should come off my plan.
Mhm.
Would she fall into almost that new job kind of category with 60 days before?
Yep, she'd have 60.
Taking off my insurance, she'd go into the marketplace.
Yep, she'd have 60 days to do that. My sister just went through that recently when she turned 26. So I was like, you need to get on your employer's plan like ASAP. Don't worry, don't wait, do it now. Don't put it off. So she did. Thankfully, she listened to me for once. So Medicare open enrollment, that is when you can enroll into original Medicare if you missed your initial or special enrollment period. You can enroll into a Medicare Advantage plan during Medicare open enrollment. You can pick up or switch Medigap plans. Medicare open enrollment is from October 15th to December 7th every year. If you roll into a plan during October 15th to December 7th, that coverage starts January 1st of the next year. January 1st to March 31st, if you have a Medicare Advantage plan, you can change the plan if you don't like it to another Advantage plan. And then you have Marketplace open enrollment. That is when you can enroll into a health plan if you missed a special enrollment period. That is from November 1st to January 15th. December 15th is the last day to enroll if you want the plan to start January 1st. December 16th to January 15th. That is, if you enroll during that time, that plan will start for you February 1st. There'd be a gap in coverage there. Buyer beware. I have seen this and it's very unfortunate. There are insurance scams out there. I've had patients recently be signed up for plans they had no idea they were signed up for because they went online, looked up for, let's say they're looking for like low cost insurance. They put their name, number into somebody's, website saying, oh yeah, I'm interested in finding out insurance information. And a rogue insurance rep who works within the ACA, the healthcare.gov went in and signed that person up for a plan without them knowing because they only needed their name, their address, date of birth to get them in a plan. So I have some patients who have insurance they had no idea that they had. So don't put your information on the internet. So if you are looking for coverage, I would try to avoid giving your information over the internet. I would call that number and talk to somebody instead of putting your information in one of those random websites you can find. There's limited benefit plans. They seem too good to be true. They're usually lower premium. They say they're low cost for real health insurance coverage. In all reality, they only cover usually 3 office visits a year. They cover like 1 X-ray, 1 CT, MRI, possibly. They only cover 1 hospital stay a year. They only cover 1 ER visit a year, and usually you pay like $500 to $1,000 for those visits. And then once you've had those visits done, you're on your own for the rest of the year. You still pay that premium for that insurance plan, but you pay out of pocket 100% for everything else. They're not worth it. There's health insurance alternatives. They cannot call themselves health insurance. They're health share plans. They are not legally insurance at all. I've seen a few patients come through with those. One of them that I see most frequently, there's this Christian Ministries health share plan. They basically, you pay your premium to them and you share the cost of all the bills with other people on that insurance plan. Well, sorry, it's not insurance, on that health share plan. They can pick and choose what they want to cover. They do put in a lot of restrictions. So let's say you were in an accident, but it was an accident for XYZ, and the plan says we don't cover accidents for XYZ. So then you're on your own, it's not covering anything. Usually you have to pay up front. So you would pay the hospital provider the bill up front, and then they're supposed to reimburse you on the back side of that. So yeah, they're kind of a hassle. And so I have some resources here. I don't know if you guys probably got these slides. These are a lot of good resources. Please remember these resources are great to go to for any information, any questions you might have about insurance. If you're on Medicare, a wonderful resource will be your local SHIP office to talk to you about Medicare coverage. I know I went over that really fast, and there's probably a lot of questions. Does anybody have any questions about health insurance? Yep.
Yeah, that was great. Thank you so much. And thanks for the help that I know you've given my daughter too. It's been amazing.
Yeah.
But I was looking at the living donor
Mhm.
and it was saying sometimes it's coming off of their plan, their insurance plan,
Mhm.
or if they were on dialysis, it comes off the Medicare plan. Is that what happens? And I thought there was like a state or federal law about living donors didn't have to pay, but is that really coming off somebody's plan or her plan?
So with living donors, yes, they don't pay anything for their testing, for the donating the organ. They don't pay anything for that. They're not supposed to, we tell them they're not supposed to pay anything for that. How it works is that any testing they have done at our facility, we're different than other ones, and some of them don't do this, but at our facility, we send those charges, off to the Medicare to have those covered. Since we're a Medicare facility, we're able to do that. Some centers will bill the recipient's insurance for their living donor workup. And so since I'm not very familiar with how that works, I can't speak fully, but my understanding is that the living donor nor the recipient would still have to pay for that testing. Usually the health insurance does cover that. Let's say if the living donor has any complications and you had Medicare at that time that you received the organ from that donor, then Medicare will cover that donor. There should be no out of pocket there for them. I'm sorry, you said about like coming off of the insurance?
Yeah, I guess I didn't know this information. I thought all living donors, regardless of where you were gonna have your expenses paid for, but it looks like that's not the truth.
The expenses are usually covered with the, like I said, so our center, the recipients or the donors don't pay anything. The most they might end up having to pay for out of their own pocket would be like traveling to get testing stuff done. But they wouldn't pay anything out of pocket. Now, if they have complications in the future, and let's say the recipient did not have Medicare, so they don't have that Medicare coverage, then they would have to use their own insurance for any complications they might have. So in the act of actually donating an organ, they don't have any expenses. But in the future, if they have any complications, that might be on their own. If the recipient didn't have Medicare at time of transplant. Did that answer that
Yeah,
for you?
and would that be true? So that's true here.
Mhm.
But if somebody was in Alaska and they had it, would it would there be a different policy or do you not just know? Is it state by state?
It's not necessarily state by state, it's like center by center, depending on if they're gonna send things to Medicare or not. So if they're going to use the recipient's insurance for everything because they want better reimbursements, that would be a little different than what I'm familiar with. I wish I could answer that for you. Yep, that's why I like our center, because we're pretty user friendly when it comes to those things for the most part. Anything else?
Just something that we found, the insurance is pretty quick to say, we fit in this box or we don't want to know you.
Mhm.
I found that I could negotiate with them and get them to go quite a long ways outside of the box.
Mhm.
But it kind of comes under the heading of you don't ask, you don't get.
Yeah,
And most people don't realize that option is there.
yes, that is correct. There's my own dad even had to do that for my sister and I getting ophthalmology care under his health insurance plan because they said they cover one visit, but he ended up pushing them to cover our 2 visits we had to have each year under that plan. So yes, even if you've been told no, don't take no for an answer. The health insurance, yes, keep pushing that limit there and know your rights with it too. And usually you can go with like your health insurance plan documents and just know that front and back, because the person you talk to on the phone too, when you try calling and asking questions, they're reading the same paper information that you have. So you might know your plan better than the rep who's quickly trying to read through what they have on their end. So don't let them fool you.
I found that generally speaking, anything out of the ordinary, you're better off talking to a supervisor.
Mhm. Yep.
And again, that's something most people don't know.
No, that's correct. Yep. Talk to supervisor, ask for names, ask for reference numbers, keep track of the reference numbers. So when they try denying a claim later, you say, no, you told me this on this day, talked to this person, had this reference number, and then you have to argue a bit more, but that helps when you argue all that.
If you're able to get extremely expensive chemo covered, that they basically said they didn't touch.
Mhm.
So anyway, thank you.
Yes, thank you.